My name's Eben Kermit. I work at Stanford Healthcare. I'm one of the supervisors in Biomed, and we have a hospital. It's under construction, should open in about a year and a half from now, which is 825,000 square feet on 5 floors. So that's part of the background of what I do, and I'm just thrilled to be here, and I'm glad to see that you're all here. The topic is a culture of safety, and that's not a new phrase or term. I didn't invent it, but I certainly resonate with the concept. And let me just start off by saying that the important part here is culture of safety. This is something that affects the entire organization from top to bottom. It has to be supported by the C-suite, all the way down to folks who transport supplies, clean rooms, do the menial tasks, and everybody in between. And part of this is based on, well, I'll say the golden rule. I had an opportunity to be an inpatient earlier this year, and it's a whole new perspective. I actually wrote an article on biomed from the other side of the bed. This affects everyone. Could be a family member, could be a friend, a neighbor, a colleague. Everyone is affected by this culture of safety. So what we're going to do for the next hour or so is an open forum roundtable discussion. You guys get to do all the work, the heavy lifting. My job is to be a facilitator. I've come up with some questions. Some of them you will see repeated in different variations. And then I have a few thought-provoking scenario type things that I'd like to go through. So any questions about the format and what we're going to be talking about? No questions. Okay, crickets. Let's go ahead and start. All right. So what is a culture of safety? I mean, I've done an introduction, but let me open this as a first pass for the collection of folks here who work in healthcare. What's your idea of a culture of safety?
Is the entire hospital system's buy-in into patient care and wellness and keeping the patient safe. It starts from the VP all the way up to the lowest level to ensure that the whole mindset of everyone is, how do I maintain safety in this facility?
Okay. And why is that important? Someone else.
And we've found that you can't institute a policy of safety. You need boots on the ground everywhere to find all of the things that can go wrong. And people need to feel comfortable and accepted in bringing those efforts forward.
Okay. Anyone else? What about cost risk or cost benefit of safety? Does this come for free?
It's investing in the right device, technology, training, process, standardization, so you're not taking shortcuts and all that. And you don't want, it's more expensive, I think, to not take, it's more expensive to take a risk because you'll have infections you'll be paying for and getting denied coverage because they acquired it in your hospital and so forth. So the cost is, your saving cost.
Okay. So cost risk or cost avoidance. Okay. What else ties into this cost benefit question?
Malpractice.
Malpractice?
Malpractice. I mean, we saw that with the Olympus scope recall back in 2016. 300 patients died. Hospitals get sued left and right because of improper cleaning, as well as the vendor. So the risk in using that and then the cost associated was devastating.
What about continuity of Go ahead.
Surgical site infections and things like that calls back to the hospital is pretty staggering.
Okay. So what is it about this culture of safety that could change that paradigm? Let me come back to you. If you use the example.
I'm sorry, say that again.
What is it that you could do in terms of this concept of safety that would have improved that situation?
Well, I mean, right now you've got a lot of scopes and things like that. You get into what is the effective way to clean them, and from one point to the next. Do they, is it something that goes out of tape? Is it something that you hang in a closet? How long can they hang in a closet?
What about engagement with our manufacturing partners, the folks who design and make devices that we buy and use? Is that part of this equation?
Definitely. It's also holding a database of IMUs for how to use everything. That works too.
Okay, so there's some regulatory issues as well. Medicine healthcare is a regulated industry.
I just wanted to stick another piece in here, cost versus risks. Sometimes the costs are not worth the risks you're trying to ameliorate.
Okay.
For instance, one of our hospitals decided that all their biomeds needed to wear steel-toed boots. And that was their solution. There we go, we're taking care of safety. And what's the benefits of that?
Well, if you drop your electrical safety analyzer off the cart and it lands on your foot with the steel-toed boots, you're in better shape. But
And when you go to MRI with your steel-toed shoes, that's the composite toe shoes are good too, but they're almost twice as expensive as the steel-toed. They make composite toes too.
The thing is, they kind of look at it a certain way, and they don't take into account what are the conditions that actually make a difference here.
Okay, so we're talking about culture change here. So how can we who work in the healthcare industry change the culture so that doing bonehead moves like inviting people to wear steel-toed boots may not be the best investment?
Vetting some of those technologies or devices or processes and training to see, invest on the front, what is worth the investment on the front end to save the cost.
You've touched on another key element, which training. How many have required training for staff in your institution? Everybody does, right? And for nurses, it may look different than it does for an ultrasound tech. It looks different than a biomed. But there's a place for training in our culture. How can we leverage that to make wise choices that are efficient, that are effective impact on healthcare? Thoughts?
Sorry, some of those trainings where everyone's just going through the annual training and ABBA, BCD.
And it's the same module you saw last year, right?
Yeah, exactly. And, give it some meaningful, make it meaningful for them instead of just, here's the sticker.
Right. Then again, previously in my career, I was a professor, and you know how easy it is to create a lesson plan and a lecture. For every hour of lecture time, it was like 15 to 20 hours of putting it together. So again, it takes some effort. It doesn't come for free, but you're absolutely right that if you have training materials that are on target, on message, and are interactive or interesting, makes a difference.
Yeah. To your point, though, we I think we all are subject to all those electronic trainings we get every year that we are bound to have to get done. And a lot of those have to do with safety, right? I mean, I'm talking like patient safety, infection control, that kind of thing. And the best of some of the better organizations I've worked with, which I've worked at Stanford with, Eben and I are both colleagues, it kind of comes down from the top. Is the culture of safety for me is, sorry to step on this a little bit, is people got to feel secure enough and safe enough to bring up issues. It kind of comes from the top down a little bit. From an RCO, CEO is pretty active, but it has got to be a culture where a technician or a nurse or whoever it might be, a scrub tech or whoever in the OR, it's got to feel safe enough to go and say, this is not being done correctly, without being retaliated against, without being, and also it's not falling on deaf ears. That's a fear as you come up, you have a complaint that really affects safety, really affects people that are in their beds, that are in the hospital beds, expecting a certain level of care, which could be improved, but it has to be acted upon.
Okay, so our hospital did two things. One, they created a no-fault reporting mindset to say you can report something that happened in the hospital at no fault to you, but just be honest in your reporting. Mm-hmm. The other thing that they did was we created the GPS Ambassador Program. And the Ambassador Program is every year they add 100 employees that fit the description of what an ambassador should be. They don't hold their tongue. If they see a gap in the industry, if they see a gap in the hospital that needs to be filled, they speak out about it. And we can take it up to leadership and say, we found this and this is our solution that we came together with. They also can find patient safety issues that they found while working on the floors, and we bring that to light in front of leadership so they can see what goes on. But we always come with solutions. We don't just come with problems. We all discuss it.
That's so important.
Yeah.
Nobody wants to have the problem statement dropped on their doorstep with no thought of here's a suggestion for a solution. Here's a prioritized list of what you could do. This one is preferred because is a whole different scenario than, oh, this is broken. Right? There's something else I'd like to tie in. I'm sure you've all experienced this. There's a Japanese term called gemba, which is literally translates as in the workplace. And this is, for those of you who are old enough to remember HP's management by walking around, visiting the workplace. When you show up in person, guess what happens? You may have a primary conversation that some business that you wanted to conduct, but how often do you get a nurse or a manager who comes up and says, oh, while you're here, would you take a look? We've been having problems with this ECG machine over in the corner. Can you take a look at that? Has anybody had that experience where by showing up, they will start talking about issues that if you weren't there, you'd never know about? Tell me more about that.
Wasn't that big a deal. But I was up on the telemetry ward, and they said, oh, while you're here, we've got a problem with the blood pressure machine. It's just a leaky cuff, but it wasn't more than 5 minutes to solve it.
So what would have been the outcome had you not been there?
They would have probably tried to work around it.
Okay.
Use other machines or drag stuff in. This is a patient isolation institute, so that's a bit of a pain in the ass.
All right. But what is the consequence of a leaky cuff?
No,
inaccurate
or
and how does that affect healthcare?
you have to take care.
Misdiagnosis.
Exactly.
Let me ask you something though. I mean, how many facilities have gotten away from Biomedical rounding in the morning? I mean, because to me, as a tech, first thing I do is I would go up on the floor to my department and good morning, how you doing? Is everything okay? Are your devices okay today? Just to create, number one, that relationship, and number two, to make sure that everything is working properly for them.
We brought it back to it. We made it more formalized as when we should round. So it's around huddle time. It's like just prior to their group huddling. So they're available. It's before shift change, not directly after. So we're getting the reports from the nurse who experienced it, not the nurse who was told about it from the previous shift.
Right.
We've gone more formalized to do more rounding, actually.
Yeah, and I'll tell you, we went away from it for a long time just because of staffing and turnover, staffing turnover, and that lack of staff. And we said we have a huge facility, so it's kind of hard. We don't have dedicated. We only have a few dedicated areas, ORs, cath labs, things that we have to have dedicated technicians. All the rest of them are kind of just the general floors and stuff like that. ER and the ICUs kind of a little excluded, but we started doing exactly what you said before. Started doing some more formalized rounding where we're going to have the emergency phone for the day. That's their job, to answer all calls and to start walking the floors. Clean utility, soil utility, crash carts, that kind of thing. And we've gotten, in the last 3 months, 2 or 3 months we've instituted, we've been getting a lot of good feedback about saying, it's nice to see a biomed.
Yeah.
You know, at least, even if it's once a week, that's a huge improvement of not at all.
Yeah, but you know what, that actually helps with that culture of safety, because once they get to know you and they trust you, it's about, they know that you're going to keep them safe and they can rely on you. So it's very important to maintain and build up those relationships.
And I think grounding is very important, and I would caution you, there's one other thing to think about though. If you do it very frequently, always at the same time, you actually introduce delays. If they know that you're going to be here tomorrow morning at 7 o'clock, if something happens after 7 o'clock, oh, I won't live there and look for it, or live for the bus system, and they call it or put it in the computer. I won't put that in because I know somebody will be here tomorrow morning at 7. So, although I think rounding is great, I'm cautioning you about always doing it at the exact same time every day on a regular schedule.
But I will say this, when I worked for press services, what we did was that we put a binder on every floor at the desk so that if things happen or equipment broke down, the nurses can write it in the book. So when we come up on the floor, we can look in the book and see what was done. But it's also a way for us to give an updated status on where we were with a repair. So we can write, yes, we picked it up on this date, it'll be returned on this date, waiting for parts. So that they can always go to the book too and see what we see as we're updating. But once again, it goes back to that personal relationship. I care enough about you to do this personally.
I think that's so important is building that foundational relationship, and it's a trust relationship that they know that when they call, someone will come and attend to correcting the problem. Plus, you have built the biomeds from their side have reached out, and they're more visible. They're part of the team, and that's again part of the culture. So there's also, the landscape, my term of healthcare, and we're a tertiary care teaching hospital, trauma center. We have a helicopter on the roof. We have medical students. We do scientific research. It's different than a community hospital. So the landscape, the level of acuity, the types of procedures, the types of equipment, there's a broad spectrum of how this plays out. Back to my theme, the culture of safety, it still applies. Even if you're an ambulatory clinic, you only see healthy patients that basically walk in, you still have this issue of how do you keep it safe, how do you deliver care, how do you keep it consistent. So here's a couple pictures. The one on the left is our new hospital, and I like to refer to it as the Monstop. 825,000 square feet on 5 floors. Brand new state-of-the-art single patient rooms. We've got interventional OR suites that have dual modality imaging. So you can do interventional surgical procedures. It's going to be an interesting place to work. The one on the right is our current hospital. Initial construction was back in the late 50s. And we've been doing gradual renovations and accommodation over the years. And then we also have medical office buildings and ambulatory clinics that are all around the San Francisco Bay Area. So those come with their own issues. The ambulatory clinics more CMS rather than Joint Commission for regulatory oversight. And then there's the windshield time for the rounding and the support. You get a phone call, it's at a clinic that's over an hour away, and then there's traffic. So different issues. So let me start by asking some questions about, healthcare, taken from the side of the nurse or medical assistant or physician. What's important to them? What has an impact? What affects their daily routine?
The nurse,
A nurse?
physician, equipment works when they go to use it, and it's available.
That's a fundamental.
Yeah.
Okay, an expectation. How good are we at delivering that?
I'd say pretty good.
Okay, and when we fall short?
We know about it. We don't know about it that we've done a good job providing it, but when it doesn't work out so well, we hear about it. Of course.
How about someone I haven't heard from yet?
Well, it's for the confidence too. If they have confidence that when they go to work, do what they need to do to the patient, they can do what they need to do.
Okay. Anyone else?
User issues.
What is a user?
Well, do they really understand what this machine is doing, and do they know how to use it? That's big.
Yeah. There's an adage that the surgeons use. What was it? Learn one, do one, teach one.
Mm-hmm.
And if I were a patient, I wouldn't be, feel too good about that. Right? Especially when it comes to the Da Vinci robot.
I've actually talked to one of the lead design engineers at Intuitive.
Yes, I do.
He described it as a Ferrari, that it is precision machined elements. When it works, there's no thrill greater than the roar of that V8. But when it breaks, it's expensive. Only a few people know how to work on it. It's an exclusive, repair item.
And if you and I were just kind of under our breath, the documentary that you and I both watched, The Bleeding Edge on Netflix. I don't know if anybody's ever watched it. It's very good. You've seen it? How many people seen it? A lot of people?
It's excellent.
Yeah. The Bleeding Edge is on Netflix.
Medical device industry.
Yeah. About the FDA approval and 510K, and it's amazing.
I'm going to give you, my 2 cents on this as well. Is when the medical device isn't working and you call Biomed, walks into the room with the nurse or the MA, the first thing that the nurse wants to know is, patient pain? Are their vital signs stable? Oh, and then there's this device. So, let's start on that end. Biomed walks in, he says, is it plugged in? Is the light on? If I type on the keyboard, does it respond? So they start on different ends, but they meet in the middle, right? At the end of the day, is the device, the tool, working and assisting them in the delivery of healthcare? Does that make sense? Two different perspectives, but they do meet in the middle. So I just mentioned the Biomed. What about the IT component of this? In the last few years, Biomed has shifted over more to integrated computer network devices and systems. We call on you in the back. You haven't said anything, so I'm thinking on you.
It's really out of my realm of expertise. I'm on the other side of the fence. I just came to listen to your speech.
Which side of the fence are you on?
The vendor side.
Well, we'll get back to you because the vendors have a role in safety as well. Yes.
It's kind of it's a different aspect of safety, but you're looking at patient information, that getting as a calendar out, if that's going to handle correctly, you're giving us a different level of that safety. So that gets out, or if you leaks out, if you just dangerous. Okay.
Let me be a little more specific. For network devices, what happens when the server goes down? What's the impact on healthcare?
X-ray to go down, your device and cardiology or something.
Okay. I think you had a
I don't know how often everyone else experiences this, but we are technically under IT, and still when that exact scenario happens, the perception is always, it's fine, it's just in local mode, we'll deal with the network when we get to it. They really don't feel the ramifications of patient care and patient safety. They feel IT security and they feel IT backbone issues, but not a patient issue. They're
What
just
happens
not
when
set
your
up to
PACS,
respond to that.
what happens when your PACS system goes down and you get calls from the OR or the ED? I can't get images, I got a patient here.
We troubleshoot whether or not the device is producing the images and able to connect to the network.
Mm-hmm.
At that point, we refer them to the PACS managers, because if the device is able to produce an image and connect to the network, the PACS server is likely, culprit, or there's something else going on. It looks like the device is functioning. Then we start integrating with the owners of the PACS system itself.
Other comments?
It pisses them off. Because they have to read it right from the machine, or they can't do it remotely. There's all kinds of issues.
What if the physician wants to compare the images from 6 months ago to the patient that's in the emergency department? Now what are you going to do?
Wheel the machine over.
Sorry?
Wheel the machine over.
No.
They never like that.
Well, the machine are like cardiac machines, ultrasounds. They delete the studies once it's been on the PACS after 7 days, because otherwise your hard drive just piles up.
Yeah, you can't
It's
keep it
impossible.
We work to be an advocate for the patient, for the clinicians, to IT, to say, hey, this is impacting care. It's critical condition, the patient care is affected, and they need to work with them to step it up and work with them so that, let them know when it's working in communication.
Is there any time pressure?
It's critical. You really have to have, before that problem occurs, you really have to have level of agreement with your IT folks about how you escalate a problem, because you want to know their standard health guys and tell them if you have a problem with one of your private type systems on a network. It appears that usually your first line help desk person is the newest person to IT. Before that, they were working in their cafeteria. Now they first IT, and now the frontline help desk person. So they don't know how to deal with that problem. And they might not know, depending on how large your organization is, how to escalate that up to someone who does. So you really have to have kind of an agreement set up with IT ahead of time. When Biomedical calls the system down, this is the step that you take. This is the magic word that code you use to get escalated up to get the right group of people involved.
So let me just repeat what I just heard. In terms of the culture, when you call with an issue, if it's significant, you need to have a clear escalation path that is already predetermined in terms of what you do, how it gets moved up the chain, so that, again, healthcare delivery is the goal. And so uninterrupted, continuous service, I think.
How many of you guys are involved in the IT change control boards that they have? Do you sit on that regularly?
Let me ask the inverse question. How many are not on a control board? Have no voice or visibility.
First of all, I don't even know what that is.
Well, when they want to take a network down, or you want to reroute some things, all of a sudden because you need to do a backup or a patch or something like that, you have to put in for a change.
So when we have to do that, we collectively get departments together and we figure out how we're going to do that and maintain patient safety, right? How many monitors on stick we're going to have, if they have to increase staff that day to monitor rooms individually, that kind of thing. So we are part of that, I guess.
Part of the key element in planning that is a backup strategy or a reversal, so that you're going to implement a 2.0 software upgrade and it doesn't work. You don't want to be the deer in the headlights going, now what? Right?
Yeah, kind of the old days of just like, okay, we're gonna take this down, for a few minutes and hopefully nobody notices.
Yeah.
And we got like 5 or 6 monitors.
You can totally would be seamless.
Yeah, you'll be like, okay, we're gonna flip this because we have to reboot the server down. So
Does everybody find in
the
those
change, what's it called?
Does everybody find in those change controls that your IT is aware of what patient care is going to be affected by their network?
Knowledge. Yeah.
Because ours does not. They know what sectors of the hospital and what networks, but they are terrible at translating that into which clinicians and which departments and how their response is going to have to be. They're just insulated one extra degree from where biomed is from healthcare to where they are. And, you know, there are some places where, yeah, it's fine, it'll be in local for 2 hours. Nobody minds. And there are other places where that's a huge workflow issue. And our only real purpose on that change control is to raise a hand and wave a red flag and go, that is a big deal, not a small deal. You can't do that during, you know, daylight hours or whatever it is.
So what I'm hearing is a pain point where there's the unintended consequences or the lack of awareness of the impact of what is a seemingly transparent, you know, it's no big deal when in fact it is. My question or challenge back to the group is, okay, that's not an okay thing. How do you now change your culture, going to your environment of care committee, going to the nursing administrative route of saying, okay, this isn't working. Here's a proposal for how we can make it better. And it's probably the foundation is communication. Doing the project plan as well as the risk and these backup plans that you need when you're making, you know, system-wide changes. It's not easy. And back to my other comment, it comes with a cost. Someone has to put in the time to develop a project plan, to have meetings, to talk about what the risks and the implementation and how it's going to be done successfully. So great point. Okay. So policy, regulations, and responsibilities. I already mentioned in my introduction that healthcare is a regulated industry. We have lots of regulations. If you want to develop a new medical widget, who do you have to get through before you can sell it? The FDA. So it's a federally regulated process. What if you want to sell it in Europe? I know we're US based, but there's a whole another European community that approves devices, and if you go to other parts of the world, there's different standards. What about ones that affect hospitals here in the US? I already mentioned the Joint Commission, CMS. Is Joint Commission a mandated, is a legal, is it what? Is it legal? Is a legal entity. You need to be certified and approved by Joint Commission to care for patients. It's a de facto standard that if the hospital down the street from you is TJC compliant and you are not, guess who's going to get the majority of the patient referrals? And which hospital or physician is going to want to work at? And where are you going to want to take yourself or your family?
Reimbursement stuff too, right?
Yeah,
That'd be tied to reimbursement.
Medicare, Medicaid.
Yeah, you can take CMS payment for if you're a commissioner.
Or you know, like they won't pay out if you're not TJC, give it to CMS.
And not only that, the hospitals pay a ton of money for the Joint Commission to come in and do it.
Yeah, that's the crazy thing. Joint Commission is a voluntary organization, nonprofit. So you have to call them and say, hey, I want a Joint Commission to come and take a look at my facility, and I want to be, you know.
It's expensive, and they were really pretty much been the only game in town, but now they're not really the only game in town anymore.
No, you got AOA.
Anyway, the DMV's got now probably about 3 or 4% of the market. All of anybody's been through DMV, but DMV is once a year, not once every 3 years, and it's a little bit of a different inspection.
And they do a green. You know,
yeah.
They do.
There's other examples. I'll just give you a couple from the top of my head. Is nurse call systems. If you're opening a new facility, there's a set of regulations and building conventions that you have to comply with. Sterilization of equipment. How do you document your infection control as well as equipment processing is all part and parcel of the rules of the road. And I'm sure you guys can come up with a dozen more if we wanted to spend the time.
I got a question. I'm glad you brought that up. Sorry, I'm asking all the
Please.
questions, but I think we have a lot of time. So
I got a lot of
about
slides.
affecting control. I mean, that's one of those things that one of the metrics that really Biomed has a hard time keeping up with. And how are we doing with infection control within the hospital? We've got a lot of dirty equipment in our hospital. Is it we ask people to bring only clean equipment into our hospital, and then I guess there was an expectation that it goes out of our departments clean. Although our staff isn't really trained how to clean equipment, So and there's really no good way to track all of that. I know years back we were talking to some of the conferences about new metrics that Biomed could actually put out to actually increase patient safety, and one of them would be some kind of way to track infection control and cleanliness of the equipment. Even as much as hand washing for nurses would be kind of like what we with Biomed or clinical engineering would want to do. I've been racking my brain for years. I can't figure out any way to monitor, measure, even a forum like this. I think it's infection control similar to this one. One of the other rooms talking about this, but you and I worked together for years. I don't know how if we know how to do it other than to say, don't bring us dirty stuff, and because we can't. When we get done fixing it, we got to send it back to you so you can thoroughly clean it. Because I don't know about you, but our entry level bombers don't know how to clean a piece of equipment. I don't after 35 years know how to clean one effectively. So, Ben, you're in the back.
Now I'll make a statement. On the other side, because one of the things we do with depot service, and that is a very big concern of ours, is the equipment when it arrives in our facility should be at least disinfected. And we have no way of telling. I think 90% of it comes in is not. Yes, we have a protocol in place that it gets disinfected first, but it's a concern from our standpoint also.
Let me ask you a question. How do you direct them to disinfect it? What's disinfectant mean to you?
Disinfectant, as soon as it comes in and it's received and taken out of whatever packaging, it goes on to a certain carts, and then it is sprayed down with the disinfectant. I can't tell you the name of it, but sprayed down and wiped down and so forth. So we actually wipe the equipment down too.
Right. You know how many different tops of cleaner wipes we've used over the last few years? I can't even count. It makes my head spin off. We're using purple or green hydrogen peroxide, bleach, all the different kind of cyto mixes we've been going through over the years to make sure it gets, because cleaning a piece of equipment is different than disinfecting. As far as I'm concerned, you mop the floor to clean your floor, that doesn't disinfect it. So it is
a disinfectant, the liquid disinfectant.
Yeah, gotcha.
I could take that back to a 30,000 foot, perspective. You treat everything as if it was expected to come in dirty before you can proceed.
Okay, so one of the things that happens at our hospital if medical devices not clean, it has to be clean and in a green bag before we would take it. Because one of the biggest things that we're concerned about in the shop is cross-contamination.
Sure.
You got all these clean things in here, and somebody brings something to the door. If it's not clean, we don't accept it. We send it back, and they have to clean it before it comes down. But it's also before it goes back on the floor, we treat it just like if any corrective or PM you do, the last thing you do is you do electrical safety. So why not the last thing you do is clean it and put it back in a new green bag before you send it out? Same thing.
Does anybody sit on the environmental your infection control board at all?
Yep.
You do?
Yes, absolutely.
Oh, good for you. You have a question?
Is there a follow-on comment?
I think that is a challenge dealing with the equipment operator, cleaning as well as user maintenance. And how do you manage both? Most of the medical equipment, I guess, joint commission problems I've seen when talking to my colleagues and whatever has to do with like creating an ADM because a customer would change the water out once a month and I track the later versus every 2 weeks or something like that. And were they cleaning it with the right manufacturer recommendations? And actually, the hospital decided to create a position for that within infection control. And it kind of carries over between education, infection control, and biomed, and to teach staff what the proper cleaning methods as well as user maintenance, like changing out the water and the TV 700s and stuff like that. We'll see how it goes. So, the person starts next month, so it'll be interesting.
Yeah.
What about blood and electronics? Do they drop a bag of blood on like a patient getting module or on an ultrasound machine? Who's gonna clean that?
Yeah, when you get under the covers. when
Under
it's
the
beyond-
covers, everywhere.
When it gets beyond
Yeah.
surface clean, we have a whole set of work orders that come in just from ORs not using blood drapes, getting blood in C-arms and. It's a full
I hear your pain.
cleaning.
But isn't that when you take on the floor, don proper PPE, and he goes in, because the last thing you want is a nurse opening the device, or better yet, what I love, they'll take the device and drop it into,
A biohazard bag.
that sterilizer, the one that, I'm sitting here like, why would you do that? It's water. But they're just like, well, it had blood in it. I'm like, the sonic washer. They throw it in the sun, I'm like, still like, really? But they'll do it.
I agree it's a biomed function. We have been more engaged with ours is OWLS, but it's essentially like a safety reporting structure. So that when we get that work order, we're also attaching it to a safety work order that ties it to that case and that clinician and the staff that doesn't use blood drapes, because there's a reason we have those. And the dirty equipment or the bite guards and TEE probes, this has bite marks, we tie it back to a case. And we put that in our work orders, and we put the safety report in our work orders, and we try and tie it to a attending.
So where does your safe report go? What's your health report go?
That's institution-wide. There is a safety environment of care and safety committee that reviews them, and then as the ones that show up for different departments get routed.
Is it kind of a non-discoverable type of platform?
What do you mean non-discoverable?
People can go in there, write what they want to write. It's not
Yes.
discoverable like from a legal standpoint.
Yes.
Like when you put in there and say this was dropped in, it had a puddle of blood, and now
Yes.
we cleaned it. Now this goes forward. Kind of an inter hospital informational tool. to
Anonymous reporting of safety incidents. Yeah.
Good.
And this also goes back to that risk benefit that, if you use the drapes that prevent these spills from becoming, a magnified issue, that's more cost effective both for the staff, for the equipment, for the repair, the cleaning that needs to be done. So an ounce of prevention, it's worth a pound of cure. Okay, so does anybody have another example of a best practice with regard to this policy regulatory? Yes, ma'am.
I like to say this because Joint Commission considered me a best practice. So it's
So it's
hilarious.
you. So
I
you're the
am
best
with JPS Health Network, and I am the network recalls manager. There is no other network recalls manager in the area. So when they came to visit our hospital, just to find the bandwidth and how ingrained I am for just recalls into almost every department and aspect of the hospital, they consider it a best practice because it is about that culture of safety. It's about that buy-in, and it's about making sure that everybody knows the process and how important it is for us to keep our patients safe. Yes, I'm examining.
And you should be proud of taking on that leadership role. I mean, you're a valued resource.
Absolutely.
Okay, so I've got a thought experiment. So Spock, Kirk, McCoy, Scotty beam into the Biomed office. They have with them a tricorder. Okay, so some of you are familiar with Star Trek? Okay. What parameters does that tricorder display?
Heart. I wanted to display heart.
You mean whether they have a big heart, a giving heart, an open heart,
A working heart.
mechanical heart? What does it display?
Oxygen saturation.
I love that. I worked at Nelcor back pioneering that. Thank you. You've just made my day.
If they're blue, you know they're not getting, but still.
Unless you're a Vulcan, in which case you're supposed to be green.
If it's clean. Then we can scan a piece of equipment to show that it's got any germs on it. Since we just got off that topic. Amongst a lot of other things. Let's keep going with this trying to go there.
Okay, second question. How are you going to do a safety inspection?
Phantom person?
Ooh, I like that. You need a phantom person.
On the tricorder or on our equipment?
Well, where's the manual for this thing, for crying out loud? You know, they beamed into my office.
I hate to say it, but most people just try to do a safety inspection on it and then push it up the door. Like electrical safety.
Well, honestly, this is non-patient contact.
To the users.
Why do you think that is? Bandwidth? Just we don't have time to go through every step there is?
Culture and
Culture of what? They just want to get it done and get it out.
Just get it done. Don't take any responsibility.
What's required for an income inspection? Make sure it's electrically safe, make sure it operates, and make sure it functions, right? So I think that was the guidelines we were given by the Joint Commission. So the operation and function is a tough question. Right, to operate, you turn it on, make sure all the lights come on, and it seems to pass its post the power on self test, right? You're good to go. Function is a little different. Like for me, if I get a brand new ESU, am I looking that thing up my ESU analyzer? Am I doing a full-blown PM every time I do an income inspection? Probably not. Probably not. I mean, I've been doing it. A lot of us here, looks like we've been doing this for a while. I mean, you're doing a safety check, which really I can't even imagine. I can't even remember the last time something failed a safety check. I'm all for it because we've been doing it for a million years, but we're close to. I think we're really close to that not being something we have to do too much longer. But to do function check and operational check, they're very up to interpretation. I've actually called companies where I got a loaner in. I called them and said, "What am I doing? When I can do electrical safety tests, does that tell me the thing works?" No idea.
Yeah. No, there's lots of stuff that has like really expensive disposables.
Yeah, exactly. I'm going to get a gold-tipped fiber thing to put on the ESU that goes in the OR for the 20 minutes. I'm going to burn a $1,200 fiber. Yeah, so
for new equipment, you all gather it's usually called like the certificate of conformity or the final acceptance document. You all gather that for a brand new device that comes into your hospital?
You know,
I hear what you're saying. No, this again comes in the box. No, we don't keep it.
Yeah, we usually try to keep that. We actually scan it, attach it into our incoming inspection. And then for a loaner piece of equipment,
We get it for that.
We require the manufacturer, the vendor, to either give us that brand new statement of conformity, it's a brand new device out of the box, or it's, a loaner piece of equipment.
We have PM records.
Yeah, you're requiring to use the PM records.
Yeah.
And it's funny that we're the only hospital in the country that asks for that.
No,
No, according to the vendor. Nobody else ever asks. I know that.
I think we just stopped asking because you never get a name.
About 10 years ago, that was a tough get in the ORs because they'd come around the corner and say, "You need what?" The doctor would come around the corner, doctor or nurse manager would come around the corner and say, "You're not to let this thing in." I said, "I can't let it in. I can't tell you that it's good for you or not. I'm not set up to, I don't know how to test this green light laser that just showed up. I don't know how to test it." So I tell the rep, you need to present to me the current PM records, I said. Kind of at that point, it kind of was a little bit of a slow kind of incoming with that. It was kind of like, well, call your company and get it for me and fax it over to me at that point, or scan it to me so I can have it. If you don't have it, someone's got to have it.
Let me bring this back because I still have some more slides to go through, but the question for the group is, did they boldly go? Okay, computers, PHI, why is this important to hospitals? Want to cry? Does that ring any bells? Denial of service? What about if PHI escapes into the wild? Everybody's shaking their heads. Comment.
Pain. Water cry was painful. The whole cybersecurity patching and keeping up with patching is the current elephant in the room that we don't know which bite to eat first.
Right, and the black hats keep whittling away at new, innovative, and creative things that they can do that are nefarious, bad, and expensive, dangerous.
right? And it's not handled like a recall where, we have a central repository and we just have to respond to them. There's no expectation that we're going to get an alert that we have to patch this device. We have to go spend the time to ask all the questions to find out if we have to patch it and then patch it. And it's a whole other PM schedule. It's a ton of workload with no.
And again, back to the culture, who in the organization has leadership role? Who gets to touch this? Who are the stakeholders?
Medical device. That's our dividing line. Yeah.
I think one of our came out as an equity recall, and
Yep.
we ended up
It's like
doing a
the
ton of documentation into the equity database by everybody that touched it and all the patches that they were doing, so we keep accurate documentation of what we did it for. But that was just ongoing, we just included.
Waterhead the only one that's come through Equity, I think. I haven't seen any other equities for patch this, Windows patch needs to be on your systems.
No.
Nothing else has reached that level, and if we only respond to it if it's WannaCry crisis level, well, that's really reactive.
Let me throw in another example. Windows XP.
Yeah, we're done with that finally.
We just had 3 ultrasounds show up and have Windows.
Really?
Yeah, they added somehow in the operating system.
We could
IT won't let them put it on the network.
we could spend the rest of the hour on this topic alone. So okay, so there's a company that's actively developing a new product. It's an ultrasound machine. It fits in your pocket. It uses a smartphone.
Yeah.
For the interface, the control, and display. What are your concerns? Do you have any concerns?
Many.
You put that on the network.
We've seen 3 companies come through with this, and 2 of them are able to lock the ultrasound. So the ultrasound probe is the medical device, and the phone is then just an accessory at that point. And they are able to hardware lock the medical device to a single piece of hardware. So as long as you plug it into a piece of hardware that is owned by your institution and is up to date on all your IT assets and protocols, then they can't plug it into their phone and take pictures. They have to plug it into the hospital-owned single capture device, which we've made the wall computers in the rooms in anticipation of this.
Brilliant summary. Thank you.
That's good.
So what are the benefits and risks of this type of disruptive technologies? Hey, Dr. Smith, you got the stethoscope around your neck? Well, I'm going to give you an ultrasound that fits in your coat pocket. Is that attractive?
There's huge benefits. For instant diagnosis, if it's, a lot of times they'll want a quick look instead of dragging a big, huge machine like an Echo or whatever, or GI. They say, what the hell is going on with this person? It's very beneficial, but there's also risks. It's true.
All right. So my follow-on question is, who owns the management decision of who gets to use this? How is it connected and interfaced? How does it go into your PAC system? Image management, PHI. Well, it takes the community, and again, this culture concept that I've been talking about. This is one of the ones where your environment care needs to be able to talk up and down through the organization, talking to risk managers, talking to the clinicians, talking to the IT folks and the biomeds about how they each have a piece of the pie. Okay, management through influence. We all have this. Now, some of our employees are direct reports. They report to you in a supervisor subordinate scheme. And you can say, for this week, your priority is work orders. We got to close all the work orders before the end of the month. That is your focus. That's what I need you to do. Go do it. And then there's the folks who are not in your team. They're over in the IT side, but you need them to do their piece. Okay, so how do we establish relationships and get things done, accomplish the goals without having a direct line of command? Thoughts, comments?
Bring down
Bring donuts.
that. We did that for a couple of departments once that we needed their cooperation and finding stickers and stuff for us to use.
If you want
It's
somebody to
amazing.
come to a meeting, invite them to lunch, right? Great suggestion, and it's not that expensive.
It's all about relationships, really. I mean, you're talking about this in this regard. I mean, if you really want to influence anybody else, you have to have a relationship with them first, whoever it might be. We're talking safety and culture and interaction with clinical partners, IT partners, facilities partners, all those kinds of, it's all about relationships and being able to get to talk to them and see what's going on with them. Yeah.
Absolutely.
First knowing who they are. Yeah, figure out who they are.
For this week, yeah.
It's not easy.
Okay, here's another thought experiment. Your next door neighbor is home after a 3-day hospitalization following surgery. He mentions that his experience overall was positive, but he had sleep deprivation. It was a major problem. So they had to come in and check vital signs, change IVs. The nursing station around the corner was beeping and squawking. What's a technology improvement that you can think of that would improve the patient experience in this particular regard?
Alarm management.
Alarm management is one.
Middleware or directed communication alarms.
So that the phone that the nurse is carrying buzzes in her pocket rather than giving an audible alarm, or maybe a staged, tiered alarm implementation.
That kind of system.
I think anybody who's been in the hospital in the last any time that they can remember understands this problem. I think what they just said was really good. Alarm management, awareness that people are trying to sleep. I mean, it's really basic stuff.
There actually is some technology that will take blood pressures without inflating the cuff. So, I mean, it's coming. Quantified self, miniaturized sensors and detectors are improving. It's sort of the next.
I got to give a real world example of this. I worked in a small hospital in New York City for a short time. And one of our units had very, very, very terrible patient satisfaction numbers. They pushed on that information a little bit and found out that people were saying they couldn't sleep all night because they heard this loud squeaking noise all night long. I went up there and I pushed a couple of their vital signs monitors around, and all the wheels were just corroded and just gross. And it's like, they said, yeah, all these things. I said, how often you have to go in the rooms? Like every couple hours. So every couple hours, you see screech down the hallway. I went up there, it literally cost me $500 to change 5 faces on these old vital signs monitors. The numbers in the next month were way up. $500. Just to kind of get the push on that number a little bit to find out what the patient experience was about. It was about who would have guessed some BS4 stand for making noise on that one. But as a patient, if you're laying there, you know that's got to get on your nerves. And people don't heal well when they don't sleep. Yeah.
You gotta take that back to the PM, right? What are your technicians doing? If they're doing a PM on a vital signs monitor, they check in.
I'm kind of like with him. This kind of culture is they go to do the PM real quick, they get out of there. They do the full steps. I mean, it's
Not on the list.
It's not on the list.
It's on the list. And, I was the only biomed there, so I'm kind of probably a little bit kind of involved in this too. You kind of went in there, you rolled down your office. And honestly, I kind of wasn't really even thinking of it. I rolled down my office, it's a little bit of a keep, and so it literally took me, an order of $500, slapped those on there, and they were all done. But it brought me, I'll always remember that story. That was 8 years ago.
So sometimes the low tech, not obvious, but obvious issues are important. It's a nice summary of.
I was going to suggest earphones.
Thank you for that.
That's what
All right, I have a last thought experiment. You ready for one more? And then we'll wrap up. You're selected as the lead designer planner for establishing the hospital on the first human colony on the moon. What concerns do you have for safety?
being on the road.
Are we gonna have gravity in our facility?
Yeah.
Well, there's gravity on the moon. It's just not.
Like 1G or like
No.
0.1G? What are we
You're on the
talking
moon. And I don't think they've figured out
They figured
a
that out
gravity expander.
Okay.
Okay, so yes, we are not going to have 1G. What's the concern?
Actually, it's a benefit. They can't drop and manage as much as
If you're wearing steel-toed boots.
Patients can't throw a dot device at you because they're just becoming slow.
Okay, so what else about the environment? What happens when you want to open the window? No?
There's no windows.
Yeah, air exchange is gonna be a huge thing. Plus, infection control issues through the rooms. How are you gonna filter out the viruses because you're recycling while you're there?
Okay.
Are there any viruses on the moon?
Not yet.
We're going there. We're going to bring our own.
Let's expose them to the no oxygen.
Heat. You are going to have windows. Whether or not what you can see out there changes the heat drastically.
Okay.
All these environmental concerns.
Okay. What else? What about power? I mean, is there going to be a generator out in the solar? Okay. Tell me about solar. Does it work all the time, 24/7? Radiation stuff. Okay, so if it doesn't work all the time, now you're talking about batteries. Okay, what are your concerns about batteries?
They're expensive to replace every company.
Well, shipping. Yeah. Because they're light, right? They're very lightweight.
The disposal of them, I mean, all kinds of different things, right?
Here's another follow-up. What regulatory policies apply?
We got the market cornered though. If you need healthcare on the moon, we're it. You're stuck with us no matter what we follow. There's got to be some benefit.
Do you really care that I have a TJC accreditation? No, I don't think so.
The MHO, the Moon Health Organization.
Yeah.
Anyway, I thought I'd have some fun with this because it sort of makes you think outside of the box of what we do every day. But at the same time, it has relevance for what we do and how we go about it. So, and I hope that when we do get to the moon with a human colony, that we have a culture of safety. So, anyway, that wraps up my formal presentation. Are there any issues, comments that you would like to share with the group before we adjourn? Anything I've missed?
Are any other hospitals doing like official culture of safety training? It's a new thing they've started in the last year. And our hospital does it as these like roundtable workshops, and they specifically don't let like you send a department. So at your table, there may be somebody from risk management, some surgeon, and a house cleaner, and a C-suite. Like you just get a mix of people, and they go through this culture of safety and have these little working groups. It was a really good experience. It was a solid 3 hours, more entertaining than I thought it was going to be. But I didn't know if we were ahead of the curve on that, or if we were fairly average, or you guys are doing that as well. Yeah.
Very similar in nature. Ours lasted, I think, about 3.5 hours as well. And they seated people from all different areas of the hospital.
They specifically break us up.
Exactly.
Yeah.
It was a really positive experience for me.
We do it at JPS. They have every 3 months an LDI and an ADI leadership, and so all of the managers and leaders get together for a day, and they do all kinds of training, and you have a different rep, and they go through all these scenarios and stuff. For ADI, they do it with the ambassadors too, to show them how to keep the motivation and the level of safety and the culture safety.
We're not doing it at the manager level.
Yeah.
So what are the agenda topics? I said the culture of safety, meaning a lot of reporting about just the environment of care kind of safety, or are we talking about like infection control safety? What are we talking
It's how to report anything you see, and who would see what, and who would you report it to, and how do you make sure that the relevant info is in there, And then they walk through several examples and go through, like, if you were a house cleaner, how would you report this? If you were a manager, how would you report this? And have everybody work through a various set of case scenarios.
Are they monitoring any kind of change in satisfaction, employee satisfaction in the hospital?
That's all managed through like number of owls and repeating. So that OWL system, that safety reporting system, it's all the metrics within owls basically for that.
Really good.
So my question would be in terms of impact and follow-up. I mean, you can hold the meeting, but then what's the follow-through that actually changes
Yeah, I
policies?
think the key performance indicator is like categorization of repeat owls. So are we seeing the same report over and over again, or are we actually seeing like slip and fall on the bridge from parking lot 20? Or are we seeing one of those and it gets fixed and addressed and we don't have 20 of them going forward? So is the overall number of safety reports going up or down? And are we seeing repeat issues reported down?
Now that goes to, we have a daily safety call every morning. And everybody or representative gets on and talking about the things that people. We also have an infection control committee that has a representative from each department and area, and we actually have to physically give a report about our metrics for safety and what we're doing for infection control prevention. So it's really good.
Well, let me go through my concluding slide, and then if anybody has issues and want to come up afterwards, you're welcome to stay. There's also a one-page white paper on the culture of safety that got picked up in Amy a couple months ago. But let me just tie the talk together by saying safety is important. It impacts all of us. It impacts family members and friends. You never know when you are going to be the patient, and you would like the culture of safety established and in place. So it can be established through leadership and behaviors. In our institution, there are a set of norms of how you interact with patients, teammates, and colleagues in terms of, introductions, clear communication about what is the next step, open-ended questions about, follow-through or consequences, and, it's courtesy, treating everybody with respect across the organization. I like to think of it as the golden rule. How would I like to be treated if I were in that situation? I believe that it's less expensive to do it right, do it ways that we're mitigating risk. Even though it costs something, it still costs less in the long run. The forest is made of individual trees. We're all individuals, but collectively we're a healthcare organization. And sometimes you need the individual, sometimes you need the organization, or both. And a soundbite or a motto of patient safety begins with me. If everyone in the organization took that message to heart, I think it would have an impact on the overall culture. So with that, I will thank you for attending this session. I enjoyed preparing it and sharing with you. Thank you for your ideas and thoughts and spending some time here today.